Welcome to the second talk in the series, guys. Thanks again for coming. Today we're going to talk about seizures and epilepsy. And I hope by the end of this talk, remember we're talking broad brushstrokes. We don't try to get too detailed in these talks. It's all about giving you good, actionable clinical knowledge so you know what you're doing on the wards. That's the goal of these talks. So for most of history, epilepsy has been considered a disorder of spiritual possession. It actually means, literally, to seize, possess, or afflict. So every time you use that word, that's what it means. And it was actually first documented several thousand years ago, probably recognized before that, and seen as a disease, usually of divine or demonic spiritual possession. It's kind of interesting how it fluctuated between the two. It was actually, again, Hippocrates, a man to whom we owe much, around 400 BC, he was actually the first recorded person to actually reject the spiritual views and treat it more as a disorder of the brain. And he used one of the four techniques I'll talk to you about today quite a lot. Unfortunately, despite Hippocrates' brief life, his efforts did not manage to change the paradigm. The spirits continued to be blamed. People were stigmatized for centuries. And in fact, there's this treatise on witchcraft called Malleus Maleficarum. I'm not quite sure if I ever pronounced that correctly. Probably not. It was second only to the Bible in sales from popularity for 200 years. It's a very, very influential book, describing how to deal with witches and, a lot of particularly unpleasant recommendations. But it most likely described a number of people with epilepsy. So let's start talking about, before we talk about epilepsy, what's a seizure? So a seizure is simply a transient period of signs or symptoms ranging from brief and virtually undetectable events. It's like someone in, you can have like a 1 or 2 second seizure that's virtually undetectable clinically, to a prolonged episode of vigorous shaking or convulsions. And it's due to abnormal synchronous excitation of a group of neurons in the brain, which is often, not always, seen on the EEG. This is very different to a dissociative attack, which we'll talk about in a bit, which is a functional disorder, which is a brain processing issue. So this is an abnormal excitation issue. That is a processing issue. They're very different. And we look for this thing called, I'm not going to teach you about EEGs in depth, but spike and wave. You see the spike on the left of the circle and the big wave after it? That's very indicative of a seizure. It's affecting most of the leads there, or all of the leads there, I would say. And that's indicative of a generalized seizure. So a seizure can be provoked by a temporary event. And these are the top 3 in my experience: alcohol withdrawal, sleep deprivation, dehydration. Any one of us can have a seizure if you take one or more of these things too far. You don't have to have epilepsy. Okay? But seizures can be unprovoked, and that's where you start thinking about epilepsy. So where they occur for no obvious reason. The person hasn't done any of these things, and they're still getting seizures. So a seizure is a single event that can really happen to anyone. And if it's provoked, if you remove the provoking factor, it may never happen again. Epilepsy is a little different. Epilepsy is a disorder, and it's characterized by an enduring predisposition to generate the seizures. Okay, and it's technically diagnosed, we mostly hold to this rule, sometimes we bend it a little bit, after a person has had 2 unprovoked seizures at least 24 hours apart. And then you say, okay, you have epilepsy, and that has certain implications. So you make that diagnosis very carefully. You don't just wing it. Sometimes we find an etiology for the epilepsy. So etiology is different to a provoking factor. An etiology is something that probably is just going to keep on causing seizures, no matter what the person does. Mesial temporal sclerosis, it's a bit of atrophy and scarring in the mesial temporal lobe, which is a series of brain structures, including the hippocampal complex and amygdala and a few others, basically where the circle is circling. That is atrophied and or scarred, and that's called mesial temporal sclerosis. That's the most common etiology for epilepsy. Other ones would include tumor, encephalomalacia, usually from stroke or trauma, and there are a number of other ones. Okay, but I've got to say, most of the time we don't actually find a cause for someone with epilepsy. The brain scan is more or less unremarkable, and we call that cryptogenic. So epilepsy is a chronic disorder characterized by recurrent unprovoked seizures. That's very important. Recurrent and unprovoked seizures, and reduced quality of life and increased mortality. So how do we diagnose it? As we talked about in the TIA and stroke talk, you've got to exclude a mimic. That's really important. Second, assess for provoking factors, right? Is this seizure been provoked or unprovoked? If you think this is epilepsy down the road, then you try to classify the seizure type. I'm going to show you a new classification system. Well, it's 12 years old now, but it's relatively new compared to what we all probably learned in med school. Although things might have changed for you guys in med school now, I'm not sure. And arrange further investigations, which usually include EEG, MRI, brain imaging. And I'm going to talk to you about the concept of asking patients in this era of mobile phones to take home videos of events. So useful. So it's a tripartite, 3 things. So first, exclude mimics. Now, not all shakes or convulsions are seizures. And in fact, I think it's best to train yourself. Unless you know something's a seizure or you know something's a dissociative attack, call it a convulsion. You won't be wrong if you call it a convulsion. You will, I won't say frequently, but often enough, be wrong if you call a convulsion a seizure. It'll turn out to be a DA, dissociative attack, and vice versa, or it might be something else. So the first mimic to know, of course, with seizures is dissociative attacks. These are very common. And dissociative attacks can be tricky to tell from seizures. I'm going to give you a good set of criteria here, very comprehensive, that'll help you do that with a very high degree of certainty, just by looking at the patient. These are some of the other differentials of vasovagoconvulsive syncope. This is usually in a young person in the setting of dehydration or hyperventilation. The convulsions are quite short, usually less than 30 seconds. They are preceded by presyncope because it's a syncopal event with convulsions. And they wake up quickly, and they're not really postictal. They're not too confused for very long. You can get a movement disorder. I have been called to see severe dyskinesia, and it's been called a seizure as a registrar. So if the movement disorder is severe enough, it can look like a seizure to some people. Panic attacks can give you a convulsion. They can present in myriad strange and interesting ways. And I have seen one patient who had a very high fever, and they were they were basically, you know, that the fever, the rigors were so powerful that I was called to see this patient with a seizure on the ward, and it turned out to be just rigors. So keep in mind there are mimics for all these things, and don't just settle on seizure or dissociative attack. Call it a convulsion if you're not sure, which probably would be most of the time. Okay, 2 things that definitely characterize a seizure over any of these other things. One is the semiology. That's just the clinical appearance of the seizure. And the semiology shows 2 things. Evolution over time. For example, if we have a focal to bilateral tonic-clonic seizure, which used to be called a secondary generalized tonic-clonic seizure, you'll start out with some kind of aura or ictal cry, and that would proceed to a tonic phase where the patient's really stiff, and then that'll gradually build up to a clonic phase where they start to shake, and it moves with a certain rhythm, and it builds up in amplitude and frequency, and then they go post-ictal. There's the evolution of stages. That does not happen with these other mimics, particularly dissociative attack. Okay? So you've got a clear evolution. It's like a little story of the seizure. You got to look for that. The other thing is stereotypy. If someone has recurrent unprovoked seizures, i.e. epilepsy, the seizures tend to look the same all the time. They might have 2 or 3 or 4 different kinds of seizures, but they're good. All of those seizures will look like the other previous seizures that you're comparing them with. Dissociative attacks, for example, can mix it up. They can look very different. They can vary greatly in time and appearance. So these are 2 very good things to look for. But they're not the only 2. There's a lot more. How do you tell a seizure from a dissociative attack? You see a patient having a convulsion on the ward. How do you tell the difference? Okay. First of all, call it a convulsion if you're not sure. And here are the differences. With a seizure, none of these by themselves is 100% sensitive and specific, but if you get 2 or 3 or 4 of them together, you can be pretty confident. In a seizure, the eyes tend to remain open. And people say, oh, they rolled back. It's because they saw the eyes. Dissociative attacks, they're usually closed. With a seizure, very frequently, it's done and dusted by 2 minutes. Dissociative attacks, very frequently, it keeps going. Each event has a similar duration with a seizure, remember, stereotypy, whereas dissociative attacks, they can vary widely in duration. This is a good sign. The seizures, this is the no, it's not a seizure sign. So in seizures, you don't get the no. That's extremely uncommon, extremely. It's common in a dissociative attack. Hypoventilation occurs after a seizure, so they look like they're not breathing. But in a dissociative attack, they will actually hyperventilate. They are confused after a seizure. They are often emotional after a dissociative attack, particularly crying. Most of the time, the person has no recollection of what happened during the seizure. During a dissociative attack, they often have a partial recollection. They can hear voices in the background and so on. Seizures do not appear as syncope, almost always. There's always exceptions, remember. But this is frequent. 30% of dissociative attacks, it's like a drop attack. And the patient keeps having them. Absences, true absences, are extremely rare in adults. Absence seizures is a thing you see often in children. Extremely rare in adults. But with dissociative attacks, you see sudden motionless unresponsiveness that might be called an absence seizure, but it's not. It's just a dissociative attack. Okay? That's a fairly comprehensive list. If you use that list, you will, you can actually tell the difference between these two different events fairly reliably. I'll just show you a couple of videos now to help you differentiate, and I'd like you to remember what you just saw. So this first video is a lady having a seizure. She's into the end of the tonic phase and beginning the clonic phase. Her eyes are open. She is not moving her head side to side. She has a very strong tone. You can see that her eyes are deviated to the left. There's evolution. It's building up in amplitude. It's building up in amplitude, and the frequency will start to go down. Her arms are fixed in the tonic phase as well. So the amplitude's increasing, and she's going to start to slow down as she goes from the clonic phase to the postictal phase. Of course, we miss the early stages because you always do. You're not filming someone at the start of a seizure, usually. All right, but notice her eyes remain open, and now she's going to hypoventilate, and she'll be out of it. She'll be confused for a long time. She's not emotional at all. She's going to be very confused and out of it. And she won't remember anything that anyone around her did during this whole event. Okay, so you can see we probably brought about half of the signs we just spoke about, and we saw none of the really none of the dissociative attack signs there. So let's compare that one to this one. Now this is, of course, a dissociative attack. This lady's eyes are closed. She does the no, it's not a seizure sign. Her head's going back and forth. Look at the convulsions, the shaking. It's irregular. Its amplitude changes, bigger, smaller, bigger, fast, smaller. And so does the frequency. Sometimes it's fast, sometimes it's slow. And it's sort of one arm gets more of it, then the other arm gets more of it. So it kind of moves around the body a bit. And you can see there's no evolution. It's not really getting into a more aggressive clonic phase. It's certainly not going to go postictal because there's no ictus. And yeah, there it is. Her eyes are closed. And this could go on for a long time. The other lady, of course, chances are it was less than 2 minutes long. This one, a very long time. So I hope that you have a general feeling for how to tell between a seizure and a dissociative attack. It's not that difficult most of the time, actually, if you just think logically and use that criteria. Okay, provoking factors for seizures. So, not all seizures are due to epilepsy. Many of them are provoked. And again, the top three are alcohol withdrawal. It's not actually the intoxication phase, although that can produce a seizure. It's generally the sort of 24 to 48 hours afterwards. That's where they're at high risk of a seizure. Sleep deprivation, absolutely, can produce seizures, so get your sleep. I should probably do a whole talk on sleep hygiene. It's so important, but that's not strict. Well, it is mostly neurological. And dehydration, that can be a good provoking factor for a seizure. There are other things you need to think about. The person might be acutely unwell, or there could be some head trauma, or some other factor that's similar. And medications, particularly tramadol, if that's in the works, that can lower your threshold, body's threshold for having a seizure. So it's worth considering all these things before making the epilepsy diagnosis. Be very wary, in fact, of making it if any of those are present. Because again, once that diagnosis is made, it has implications for the patient and their family. Now, this is the old seizure criteria, which I'm pretty sure most of you will have learned. We divide seizures into partial and generalized. And there are simple partials and complex partials. And partials evolving to secondary generalization. And then over on the generalized column, we have different sub-classifications, most commonly the absence, which is a generalized seizure. And then you've got these other various types. And then there's always an unclassified category for anything because, we can't classify everything. You try not to use that one now. I'm not going to go over it in detail because I don't actually want to talk about it too much. This is the 2010 International League Against Epilepsy Seizure Classification. This is the one we should use, and I'd strongly encourage you to use this in your terminology. So seizures are divided into focal, and this refers to the onset of the seizure, focal onset, generalized onset. Now, this is better than calling them partial, because focal implies that the seizure starts in a focal area of the body rather than a partial area of the body. I think it's slightly more precise wording. And instead of simple, we say aware. So these are seizures where the patient retains a reasonable degree of awareness. So like the aura itself is a seizure. Or the beginning of a seizure is it's often the beginning of a seizure. And the person remains aware. It's better to say that than simple. Simple doesn't tell me much about the patient, whereas when you say they're aware, it tells me a lot more. And then you can say they're motor or non-motor. So motor would mean there are movements, and non-motor means there are not. And then you have impaired awareness seizures. So, okay, these guys are maybe unconscious or very, very reduced in conscious state, and they can be motor or non-motor. Secondary generalized tonic-clonic seizures are now called focal to bilateral tonic-clonic seizures. And again, it's more precise wording because it starts in one area of the body and moves over to involve both sides. Motor seizures and non-motor seizures are still classified very similarly. Most non-motor seizures are absence seizures. Actually, I have absence there under motor, but it shouldn't be there. So when you're, and then there's the unclassified columns, when you're describing a seizure to someone, you try to use as many qualifiers as you can, but the ones circled in red are good enough. So I often would describe most of the seizures as focal aware seizure. Okay, so they're aware, but there's an aura, some other strange sensations indicative of a seizure. Then there's a focal impaired awareness seizure. That used to be a complex partial seizure. So those are now called focal impaired awareness seizures. The secondary generalized tonic-clonic seizures are now called focal to bilateral tonic-clonic seizures. And the other ones, the generalized seizures tend to be, you can still call them absence seizures and so on. So it's some subtle changes, but quite important, I think, because it allows you to describe things more as you see them. And that's really important. The EEG. When it comes to the EEG, most of the epilepsy diagnosis is made on history, like any other neurological disorder. The EEG is supportive. You can't use the EEG to diagnose. It's supportive either way. So you can't get around a good history. Now, the EEG sensitivity is maybe 50%. So that means half of people with epilepsy do have an abnormal EEG, but about half don't, at least half. And why would that be? Well, because remember, the EEG looks at the superficial part of the brain just under the skull, basically your neocortex, which is the envelope of neurons only a few millimeters thick around the edge of the brain. It looks at that pretty well. But if you have a seizure focus that's deeper, like way in the middle of the brain, the EEG won't pick it up. So that person could be having a full-on seizure clinically, but you can't see the electrical activity, and the EEG is normal just because it's deep, okay? So the EEG, when you do see seizure activity, it's pretty good at diagnosing this is a seizure. This may be epilepsy. So the specificity of the EEG is about 80, 90%. It's quite high. So if you have a normal EEG, most people without epilepsy have a normal EEG. So basically, just remember the EEG, If it's abnormal, it does not mean epilepsy. If it's normal, it does not mean they do not have epilepsy. The EEG sensitivity can be increased with certain procedures that we do during the EEG. So these are called activation procedures. Hyperventilation, photic stimulation, and sleep deprivation are common methods. They are techniques you can use to bring on a seizure. The gold standard for diagnosing seizures, and at the moment this is only done in Auckland City Hospital, and the mimics, this is very good for diagnosing mimics, is video EEG monitoring. They basically hook a patient up to an EEG and a camera for a week and watch them the whole time. And then you can quantify the seizures clinically and on the EEG and correlate them and see, okay, well, this is this kind of seizure and it's coming from this part of the brain. However, if you don't have that, and most people will be working in a situation where that's not available, a home video is very good. So you ask a patient's family member to just take a video next time they have a convulsion. It might sound a bit strange to ask someone that, but given that they've probably seen most these kinds of convulsions before and know that the vast majority are basically harmless, they're probably okay with that. It's a very useful technique for you being able to look at one of these events and then use the criteria I showed you to actually make the diagnosis. Brain imaging is often used because we want to look for the etiologies of epilepsy. So mesial temporal sclerosis will appear as a slight hyper-intense signal on the MRI, and the arrow there is showing you the hippocampus there. Compared to the right side, these can be very subtle and very difficult to see, but it is very good if you know exactly where to look. So remember, MRI is about intensity, CT is about density, so hyper-intensity in MRI is a little whiter. You can also find tumors in encephalomalacia. Tumors are if someone who's older has new onset seizures, no provoking factors, be very wary of a new tumor. Anyone really, but especially an older person. There are other etiologies that as an adult neurologist we see much more rarely, but in pediatrics you can see quite a bit. So gray matter heterotopia, which is where the cortical cells that normally form the cortex, they don't quite migrate all the way out there during development, and they get stuck in the white matter. So, and it's a problem, so they become a seizure focus. Vascular malformations can become a seizure focus. Focal cortical dysplasia is very common in kids, and that's where the cortex has simply developed abnormally. And we use MRI, sometimes PET or SPECT to look at these things, usually MRI. So I'll just show you a few examples. This would be, I want you to appreciate how subtle these seizure etiologies can be. This is a tiny ganglioglioma, a small tumor. And there's just a very bit, I would say it's reasonably subtle degree of hyperintensity. That circled area is a little bit whiter, and the cortex you see on the normal side, the sort of whitish cortex is quite easy to appreciate, but the part in the circle is a little blurred. This would be gray matter heterotopia, so cortical cells that didn't quite make it out there and they got stuck in the middle of the occipital lobe when they should have gone all the way out to the cortex. And you can see it's just a little hyper intense in the right occipital lobe compared to the left. And this is an example of left frontal cortical dysplasia. Again, the cortex on the left looks a little bit abnormal compared to the right. It's a little thicker, it's a little more hyper intense, and it's ill-defined. You can correlate MRI and PET. So this is the same pathology. On the left is MRI, on the right is PET. So the MRI, again, this is the left frontal cortical dysplasia showing the slightly ill-defined, thickened neocortex. And what the PET does is it looks at metabolic changes. I won't go into the details. It uses tracers to look at metabolic changes, and you can see that there's a change in color there in the same area. So when these two things correlate, you can say, yeah, definitely that's the problem. It's structurally there's a problem, and metabolically there's a problem. So a diagnostic approach for seizures and epilepsy is as follows. Take a very good history. That's the backbone of any diagnosis. Consider the mimics and provoking factors. Often you will need collateral history for these because the patient cannot give you the history, and a witness is far more reliable than the patient. If the convulsions do sound like seizures, try to classify them. If the history suggests an unprovoked seizure, so you're probably looking at some kind of epilepsy, order an EEG and MRI. However, if you had a provoked seizure or a mimic, you may not need to order those. If the diagnosis is still unclear after you've done the workup, we're well into the outpatient stage now, then you could order video EEG monitoring, or if not practical, I often ask a family member to just take some home videos. The treatment of seizures and epilepsy is really where it gets interesting, because there are a number of ways you can treat them now that you may not be aware of. First of all, if you have a provoked seizure, this is not epilepsy, treat the provoking factor. You'll probably remove all, further seizures. Someone who, has very poor sleep and you correct their sleep, well, guess what? You probably will fix the seizures if they were related to sleep deprivation. I'll just tell you briefly how to manage status epilepticus. So this is the acute stage. And this is defined as a seizure that lasts over 5 minutes or 2 or more seizures within 5 minutes where the patient does not return to normal awareness. So they can have this for an hour, 2 hours, 3 hours. Not returning to normal awareness, that can be status epilepticus. Status is generally very easy to treat. It's just that it kind of looks spectacular a lot of the time. So it tends to make people nervous. As always, you'd set up 2 lines. Often we would give some thiamine, IV thiamine and dextrose, just in case it was related to one of those 2 things being out of kilter. In most hospitals, you'd give a benzodiazepine. In our hospital, we tend to use midazolam. In my previous hospital, clonazepam. So the hospital protocol will tell you which of these to use, and just follow your local hospital protocol. Now, if it's status epilepticus, that's not going to hold it for very long. And what you need to do then is pick a drug that will stop the seizures permanently. Well, at least 24 hours to give you a good night's sleep and the patient. So it doesn't matter so much which one you pick, as long as you pick one and you get that to the right level. The mistake that is often made is people go, oh, I use one and it's not working, so I use another and it's not working, so I end up 3rd, 4th anti-epileptic. And the problem is none of them is at the right level. So phenytoin, this is the only time when I actually use phenytoin a lot, is to break status epilepticus. And 20 milligrams per kilogram IV. Take the blood level an hour after that. This is crucial. If you take the blood level, and the normal level is sort of given in our system as 40 to 80 micromoles per liter. But with trying to break status epilepticus, you want to go super therapeutic. You want to go 80 to 120. Something around 100 is perfect. Even if the patient has a little bit of phenytoin toxicity, a bit of nausea, ataxia there in bed, so breaking the seizure is more important. And if the level is well below that, then you give another 10 milligram per kilogram dose and keep measuring the level and giving more and measuring the level. And you keep doing that process until you've achieved the slightly super therapeutic dose. And you'll break virtually almost all status epilepticus with that simple method. The difficult part of the method is appreciating that you have to actually get the feedback from the blood level and keep taking it up. An alternative is valproate, if for some reason you don't want to use phenytoin or it's contraindicated. Same strategy. And as a last resort, you can break any seizure with intubation and general anesthesia. That's not ideal. If you can avoid it, it would be great. So the whole ethos here is getting one drug to a super therapeutic dose will terminate the vast majority of seizures. And if it doesn't, you've probably got something going on that requires a different kind of treatment. For example, an autoimmune encephalitis. Maybe there's an area of inflammation driving the seizure. You can throw as much anti-epileptic drug as you want. It probably is going to struggle to treat that. You may have to throw on some powerful immunomodulation therapy, such as plasma exchange, in order to tag team the problem. So, but this approach, this simple approach, will stop most of these seizures very well. Okay, treating epilepsy in the longer term. First, as always, I think it's a great idea to explain diagnoses to patients, put them into context, discuss what it means. A lot of people hear the word epilepsy, they don't actually know what it means. So you talk about the healthy practices such as minimizing alcohol, maximizing sleep, and hydration. There are legal ramifications about driving that you have to convey, and the default in New Zealand is 1 year for that. Provide community support for them as well. Now, there's a lot more to the explanation than that, but I think those are things that are all compulsory in that explanation. And then you discuss the potential therapies that can be used. So there are actually 4, and I suspect most people will only know of 2. We get told about anti-epileptic drugs, or AEDs, a lot. And most people, I would sure know that there is epilepsy surgery available for select patients. It's rarely indicated, but even so, still underutilized. The third one is the ketogenic diet. Some people might know about that one. Well, if you've seen me speak before, you definitely will know about it. So this is often indicated. It's definitely underutilized. The fourth one is the one that Hippocrates used. I'm not going to talk any more about it because it's not really the thrust of the talk, and it should only be used in certain situations. Well, that's debatable, but it is, of course, fasting. That's the oldest epilepsy therapy of all. Virtually never utilized. I do use it with some patients, a number of patients, as a add-on, as an adjunct. So Hippocrates used it a lot, but that's all I'm going to talk about fasting today. So AEDs. These control seizures in 2/3 of people. 2/3 of people with epilepsy can be controlled with an AED. So that is very good if you can give them an AED that is sort of twice a day and the seizures are controlled. That's wonderful. The first AED will control seizures in 50% of people with epilepsy. If you add a second, another 12, 13%. You add a third, you get another 2 to 3. By the time you get to sort of 2/3, there's no point adding a fourth or a fifth or sixth. You're not statistically, you might help a little bit, but statistically you're probably not going to help much except give them more side effects. The disadvantage of the drugs is, of course, they produce adverse effects. Probably about half the time they're noticeable to the patient, and about a quarter of the time they're so noticeable that they really probably need to try a different drug. And also, here's our AEDs. Now look, up until the 1940s or so, that's when phenytoin came out. In the textbooks, the standard treatment for epilepsy, and if you were doing medical school back then, it was the ketogenic diet. That was the main treatment for 20 years, 25 years. Then when phenytoin came around, people went, these drugs are much easier. And so the drugs gradually took over. And now the keto diet was not mentioned in textbooks, in the last 30 years much at all. It's kind of making a comeback now. But you can see that a lot of drugs, about 30 of them, have been added. I don't think I have all of them there. But despite that, the definition of people with drug-resistant epilepsy, that unlucky third who can't get control with the drugs, it hasn't changed much at all. So although we've got all these extra drugs, we actually haven't impacted the epilepsy that much, okay? So, and how do we define drug-resistant epilepsy? That's the failure of 2, some people say 3, but generally 2, appropriate, adequately dosed AEDs for a period of 6 months. If they have done that and they're still getting seizures, that's drug-resistant epilepsy. Okay. Selecting the AED depends on several factors, but I'd like to impress on you today that the main factor is this one, the adverse effects. You think about your patient, you think about the top adverse effects of the drug, the AED, and you don't want to put the patient who's prone to the adverse effects of that AED on that AED. And I'll show you some examples on the next slide. Other things you consider are age, gender, the type of seizure, and the comorbidities. I would strongly recommend, even as a medical student, you become familiar with the top 2 or 3 adverse effects of the sort of common 6 or 7 epilepsy medications, AEDs that we use. It's so easy to remember them. You explain them to the patient. It'll just be so useful for yourself and patients because you'll see these adverse effects even if the patient doesn't see them. So here's some examples of the top 7 AEDs that we use a lot in New Zealand. Phenytoin and carbamazepine, for example, are not generally good in elderly. The reason is their main side effects involve ataxia or disequilibrium. And so people who are elderly might generally have more balance issues than people who are younger. So right away, you want to consider, this is not absolute, you just want to take this into consideration. Better choices might be lamotrigine, topiramate, or levetiracetam. Young women of pregnancy-bearing age, you want to avoid valproate and topiramate. Why? They're numbers 1 and 2 in terms of teratogenicity. For them, you prefer lamotrigine, levetiracetam. They're the kindest for, in terms of, there's really no major studies that I'm aware of showing that they have a high risk of teratogenicity in people. Levetiracetam is probably overprescribed. Definitely want to avoid this one in anyone with a mood disorder, and that's actually a lot of people. Anyone with a mood disorder, you're not going to do them any favors by putting them on this drug. It's very, very likely to worsen the mood disorder. Anxiety gets worse, depression gets worse, irritability gets worse, anger gets worse. So just be aware of that. There are some other alternatives that you might want to try. So that's the most important thing to think about, I think, when you're starting an anti-epileptic drug on a patient. Surgery. Surgery is very effective in select cases of drug-resistant, disabling focal epilepsy. It's got to be drug-resistant, disabling, and focal. Otherwise, if you can make it go away with a single medication, why do you want to go through the surgery? Now, the seizures have to emanate from a region with a minimal risk of postoperative disability. So if it's in a region that's very important to, say, speech, you might be able to help the seizures. However, if you remove that person's ability to communicate, it may not be worth it. So with an MRI-proven temporal lobe lesion, the resection success is that about 2/3 of people have seizure freedom at 2 years. But I got to say, most of those people still have to take some AEDs. There are some, about 25%, that can get off all AEDs after the surgery, and that's great. But remember, they're in the minority. Disadvantages of surgery: only a few people are eligible, and quite frankly, I've had eligible patients who still don't want it. They don't like the idea of having a part of the brain removed or resected. And adverse events, of course, can occur. Major complications are rare, but not trivial. And long-term neurological dysfunction is very rare, but not trivial. So these are the kinds of things you have to think about. Some patients are very suitable for this, many are not. Keto diets. Now, keto diets are high-fat, adequate protein, low-carb diets. And there really is a lot of misinformation about these. What they do is they force the body to burn fats as the primary energy source. You become sort of fat-adapted is the common expression. And in epilepsy, we don't know how they work, but they work well. And two possibilities is that they enhance neuron energy metabolism. We know they do that. And they reduce neuron excitability, both good things in epilepsy. Anyhow, if you look at the data, the problem is the good studies on keto diets in epilepsy have only tended to look at the people who have failed the other therapies. So you've got the toughest drug-resistant epilepsies in the studies. Despite that, they confer a greater than 50% improvement in seizure control in up to half of adults. Kids, it's better. So I'm just looking at adults. With drug-resistant epilepsy, 90% of people with a described or diagnosed brain metabolism disorder, the most common two would be GLUT1 deficiency syndrome and PDHD, and 60 to 70% of people with JME, juvenile myoclonic epilepsy, which is very common. That's 5 to 10% of all epilepsies. So basically, you've got probably about half of all epilepsies. You've got drug-resistant epilepsy, which is 30 to 40%, and then you've got 5 to 10% of JMEs. Half of these people, there's fairly good evidence that you could improve them significantly with this approach. And there are other potential benefits on cognition, energy, mood, quality of life, which I don't have time to show you the data for, but they exist. The disadvantage is that it imposes a culinary and social restriction on the patient. So the trouble is you remove an adult, you restrict them a little bit in terms of what they can eat and how much they can go out to eat. Now, it's not so bad with the newer keto diets. The old ones, this was a big problem. The newer keto diets, it's really not bad at all. And I have a number of patients who go out a lot and associate a lot with people who are on these. And basically, another thing is they won't be adhered to in the longer term, and this is critical, unless the person is self-motivated. They have to want to do it. They have to want to improve themselves this way. If they don't want to do it, if they're just being told to do it, it will fail in the long term. Okay, there are 4 conventional keto diets. The classic keto diet, this is 100 years old. The circle there shows the blue is the fat intake, the red is the protein, the green is the carb. You can see this is almost all fat. Now, I should say that the keto diets are basically mimics of fasting. They put your body into a semi-fasted state. That's the only thing special about them. There's nothing else really special about keto diet. When you fast, you're going on 100% body fat, and it can be a very good state, fasting. Keto diet's just trying to resurrect that. So fasting improves seizure control, as do keto diets. almost assuredly it's a similar mechanism or even the same. There's another diet, it's about 40 years old. It's maybe 50 years old. The medium chain triglyceride or MCT diet. What they do is they ease up on the fat restrictions by replacing some of the fat with MCTs, which is medium chain fatty acids, triglycerides, and they, in my opinion, this has decent evidence for it. Some people like MCT oil. I am not a particular fan of it, and it can be very beneficial. Basically, the MCTs are processed much more quickly and easily into ketones, which are the energy molecules that your fat becomes on these diets, and that's what the brain is running on. Then there's the modified Atkins diet, or MAD. With the MAD, it eases up on the restrictions even more. There's no need to weigh the food, so it's less restrictive, but it's not as powerful as the other two. And the least powerful is the low glycemic index treatment, or LGIT diet. And that allows even more carbohydrates. However, it is the weakest of the four. Now, that being said, there are newer modified ketogenic diets, or MKDs. These are also available, and these have actually become very popular in the last, I would say, decade. The advantage is that they're easily tailored toward a person's taste and ethnic preferences, so making them much less restrictive than conventional options. And the example of the pyramid I've shown you here is it's basically meat and vegetable. It's what it is, with some oils, healthy oils, hopefully. So olive oil, coconut oil, macadamia oil, avocado oil, coconut cream, fats. You can throw in some berries, and you can have a lot of nuts and seeds too. And another advantage is they have myriad additional metabolic health benefits. They're really very useful. There's plenty of randomized controlled trials now. There's dozens, actually, scores of them, showing that these things improve type 2 diabetes and very good for weight, reducing hypertension, all the factors of the metabolic syndrome. The disadvantage is that there's a very, very small portion of the population that are not suitable if they have a disorder of fat metabolism. I almost never see these in adults. They almost always occur in children. So you got to watch for these things in children. The main problem, why are they not being used more, is there's a lack of general knowledge about them. And again, all they do is recreate the fasted state. So there's the diet wars, these are excluded. So you can be vegan keto, you can be carnivore keto, and everything in between, it's irrelevant. What matters is that you're keto. Is that it's like an anti-diet. You're trying to recreate the fasted state, okay? So if someone says, oh, vegan is better than keto, or vegetarian is better than keto, or Mediterranean is better than keto, it's irrelevant because they're all can be keto and they can all be not keto. I personally love Mediterranean keto. I've got patients on Indian keto. I've got patients on Southeast Asian keto. I've got people on Mexican keto. I've got people on vegetarian keto and people on carnivore keto. It doesn't matter, okay? So just remember that when you get to the next pub conversation with someone about keto, why it's good or not good, that this does not matter. Okay, treatment approach. Discuss the diagnosis. Provide education about it. Again, it's always so important to educate people about the disorder you've diagnosed. Put it into context. Talk about minimizing alcohol, maximizing sleep, and hydrating, which are all really good things for most people anyways. Convey the legal driving restrictions. Again, the default is 1 year here. Provide community support. Know your local epilepsy support groups. If you commence an AED, base the first choice on potential adverse effects mainly, but also these other things, of course, come into play: age, gender, seizure types, comorbidities. If the first AED has significant adverse effects or low efficacy, i.e. it doesn't work very well, switch over to or add a second AED. No problem. Try to give the first drug at least 3 to 6 months if you can. And if you need to, you can consider the same with a third AED. Now, if you've tried 3 AEDs and you're still having problems controlling this epilepsy and you've had adequate time, you probably are looking at drug-resistant epilepsy. Now, if that's diagnosed, you can still think about further AEDs, and in reality, most of us do. We do keep trying. However, it is time to think about other options. So, is this patient suitable for epilepsy surgery? So that is useful for someone who has disabling focal epilepsy with the seizures emanating from a region with a minimal risk of post-operative disability. If you have that patient, particularly if they're young, that may well be a good candidate for surgery, and you make the referral to Auckland. I would also consider whether the patient is suitable for a keto diet. The main thing is, are they motivated? Did they ask you about it? Probably means they're suitable. So remember, there are culinary and social restrictions. We need them to be self-motivated and have the ability. Some people don't have the intellectual or financial or logistical ability to do this. We're actually forming a formal keto diets epilepsy service at the moment. We're initially aiming to include just 20 patients. Most of them will be children, some young adults. And so that hopefully will be up and running by the end of the year. Until then, you may refer motivated, able adults to myself. I have a number of people doing this approach, many of them successfully. So remember, not all shakes are convulsions or seizures. Many are mimics, particularly those dissociative attacks. Remember the criteria I showed you, very useful. And not all seizures are due to epilepsy. Many of them are provoked. So a patient has a seizure that's provoked. It's not necessarily the case that they have epilepsy. We now classify seizures using the 2010 ILAE classification criteria. Please try to apply that in practice. You'll thank yourself in a few years because you'll see that the old one is not very descriptive. And although EEG and MRI are undoubtedly useful, I would argue that home videos events are just as useful as those two, sometimes more so, when you're trying to figure out whether this person has true seizures or something else. And epilepsy treatments, we use AEDs a lot. Don't stop using those, they're great. Epilepsy surgery though, think about that, whether it's possible in that patient. Definitely think about the keto diet. If you want to think about fasting, come and talk to me. The latter two are definitely underutilized here though, the surgery and the keto diet. And I think if we could develop a less monotherapeutic approach to epilepsy, not just rely on drugs, it would be a great thing for everyone. All right, thank you very much.